Hi everyone, welcome back to our journal club for this week. I am doing our second video this week with Dr. Nicole Garber, who is about to come on. I just need to wait for her to get on the video. And this is, as I said, the second eating disorders topic. On Monday we did binge eating disorders, and today we are covering anorexia nervosa. So let me just make sure that we can get her on. And thanks for joining us, guys. I just sent her an invitation. I did hear that the questions, I'm actually eligible for the pilot too, but I did hear that I haven't looked in my own personal portfolio, but I've heard that the questions did come out for the MOC pilot articles. Hi, Bushra Hanif. And let's get Nicole on. And I've heard mixed things. Some people said that the questions are pretty reasonable, and some said that they're a little bit harder. So, hi, welcome.
Hello, can you hear me?
Yes, we can hear you.
Awesome.
Yeah. Oh, great. Perfect. I was just saying that it sounds like the questions came out for the MOC. So people have started doing some of the article questions, which is the whole purpose of our journal club. So, so welcome back, and thank you to Dr. Garber for joining us the second time this week. I won't go through her whole bio. You can listen to it in the last video, but briefly, she is a psychiatrist out in Arizona. She's a medical director at the Meadows Ranch, and she has some expertise and works with eating disorders. So we are very grateful that she is covering these two articles for us. So tonight, why don't you tell us the title of the article and let us know what the topic was about.
Great. Thank you so much. Tonight we'll be talking about the initial evaluation, diagnosis, and treatment of anorexia nervosa and bulimia nervosa. And the first part of the article really goes into the diagnostic criteria and how it changed from DSM-4 to DSM-5. The biggest changes with anorexia was that the criteria for the percentage of ideal body weight was taken away, and they acknowledged now that what you need is a negative energy balance, and so that could be causing weight loss, or for an adolescent that could be causing a failure to continue to grow, and there isn't a particular number that you need to reach. The other thing that was taken out was amenorrhea, and the reason they took that out is there's just such a wide variety of when women will lose their menstrual cycles within restricting and when they'll get them back. So for most people, if they hit about 90% of their ideal body weight, they'll start menstruating again. But there are some people that never lose their menstrual cycle, and there are some people that actually lose the menstrual cycle really before they start losing weight. So we took out that criteria. The severity scale is still based on BMI at this point in time. Then for bulimia nervosa, the biggest change with the DSM-5 was the criteria for the time. So now it is at least one binge and purge episode per week for at least 3 months, which is a little bit different. It used to be 2 episodes. And a binge episode is diagnosed very widely. So it's eating an abnormally large amount of food within a certain period of time, again within 2 hours, because we did need something to discreetly measure that time.
Mm-hmm.
And then feeling out of control, feeling guilt and shame, eating past hunger cues at that point in time. And then there has to be some sort of compensatory behavior, and that would be through self-induced vomiting. It could be through laxative use, could be through diuretic use. For some people, their restriction will be another form of a compensatory behavior. And like we talked about last time, binge eating disorder was added to the DSM-5. And the difference between bulimia nervosa and binge eating disorder, because they both have that binge behavior, is the lack of compensatory behaviors within binge eating disorder. Severity for bulimia is based on the number of episodes of binging and purging per week, and the severity of binge eating disorder is based on the number of binge episodes per week. The next part of the article goes through prevalence of this disorders. So within the eating disorders, anorexia nervosa is the least common eating disorder with less than 1% of the population meeting criteria. We're still using kind of old numbers where the ratio is 1 male to every 10 females with an eating disorder. This is likely really old data, and as we gather more information, this number appears to be getting higher, particularly within some criteria. Bulimia nervosa is the next most frequent eating disorder, and like we talked about last time, binge eating disorder is actually the most common eating disorder that we see. Most people with an eating disorder develop them in adolescence and early adulthood. For anorexia nervosa, there's two major spikes. One is at 14 with the transition from middle school into high school, and then the second peak is around 18 from the transition from high school into college. Bulimia nervosa has a little bit later of an onset, usually late teens to early 20s. And then binge eating disorder, we think, has even a little bit later of a onset, but not 100% sure. We're still really getting more material for that one. In terms of etiology for an eating disorder, it can be really kind of anything, but we know there's usually a genetic predisposition to it. For anorexia nervosa in particular, we see a propensity towards perfectionistic, rigid sort of thinking. And then oftentimes there's kind of an environmental cue that can kind of throw somebody over the edge. For some people, that's as simple as negative energy balance that we see within dieting culture. And then for some people, obviously, it can be something bigger within like a trauma. What we have found is that there used to be this idea that there was always sexual trauma or there was always poor parenting, and we know that's not true now. Although parental dynamics and stress within the environment can obviously cause some issues. So clinical presentations, there's this, for all eating disorders, there's an abnormally high focus on body shape and body weight. Within eating disorders, again, there's usually a food aversion, so restriction of what they're taking in to cause that negative energy balance. Within there can be an increase in physical activity past that. And what we often see with the physical activity is that they will continue to do the overexercising even if they are missing out on social events and with injuries. And particularly with anorexia nervosa, with that low energy balance, we see a risk for overuse injuries and particularly stress fractures as their bones are being inundated with a couple of different things. So they're not getting enough of the raw material for the bone turnover, and they're releasing cortisol, which is a stressful state, and a lot of times they don't have enough estrogen, which is also protective for our bones. We know that eating disorders tend not to run alone, that usually they are comorbid with something else. And about half of the population with eating disorders meets criteria for a mood disorder. Particularly with anorexia nervosa, the most common co-occurring condition is major depressive disorder. For bulimia nervosa, we can see mood disorders, but we often see impulse control disorders, so substance use disorders or non-suicidal self-injury on top of that. And eating disorders have the highest rate of mortality out of any of the psychiatric disorders that we treat, with it being pretty evenly split between medical complications and psychiatric complications being suicide, and particularly anorexia. So the estimated rate of having a suicide attempt for somebody who has an eating disorder compared to like the general population is about a 20-fold increase. So very, very high propensity. So within that, you can see kind of all the medical complications that can occur with anorexia nervosa. So with starvation, I think of everything gets lower and everything gets slower. With bulimia nervosa, you often have the same complications because they're malnourished in the sense of not allowing the food to come into their body. And then on top of that, they can have other complications secondary to the mechanism of purging. So they may have metabolic alkalosis if they are doing self-induced vomiting. For initial evaluation, you got to ask people these questions. My standard question for when I wasn't in eating disorder treatment center was, how do you feel about your body? Do you want to lose weight, gain weight, or stay the same? And kind of let them go through at that point in time. Then there needs to be a medical evaluation, which we as psychiatrists can order the labs and the blood work, or we can work in conjunction with a pediatrician or internal medicine doctor to get those lab results, really to make sure that they're medically stable, and that there isn't a risk for refeeding syndrome. Typically, if there's a large amount of weight loss or acute food refusal for a couple of days, that would be criteria for going into an inpatient unit to make sure they don't go into refeeding syndrome. Eating disorders really, really have to be treated as a team. So there often is a mental health lead, whether that be a psychiatrist or a psychologist. There has to be a doctor involved watching for labs, and a dietitian. They really, really need a dietitian, and then sometimes they also need a family therapist. For we do have gold standard treatments for the different eating disorders within psychological treatments. So for adolescents in particular, family-based treatment or the Maudsley method has been proven to be effective as long as there's no contraindications, such as mom or dad having an eating disorder or the family not having enough support to implement FBT, because the family really is responsible for refeeding. For bulimia nervosa, the gold standard treatment is CBT, or cognitive behavioral therapy. And like we talked about before, for binge eating disorder, the standard of care is cognitive behavioral therapy. Medication use within eating disorders has not been all that robust. So SSRIs, particularly Prozac, is FDA approved for bulimia nervosa at doses of 60 milligrams. It has been found to decrease the number of binging and purging episodes per week. For somebody who just has bulimia nervosa, which again is kind of rare, I wouldn't just start somebody on Prozac, though. We would do the psychological treatments and not necessarily start that. At this point in time for anorexia nervosa, no medication has been found to be really, really helpful for the core symptoms of anorexia, and we have tried everything and anything. That being said, the thing that we're looking at now is the atypical antipsychotics. We are not using those because of the side effect of weight gain, but because they're supposed to help with like cognitive rigidity and some of the obsessionality that people have within their eating disorder. And then with binge eating disorder, we talked about prior treatments, including some stimulant medications and CBT. That being said, we know treatment works. About half of the patients with an eating disorder, and we have the best data for anorexia nervosa, about half of those patients fully recover and can have normal, fully functioning lives and have a normal relationship with their body and with food. About 30% achieve partial recovery, which is usually kind of weight stability, medical stability, but maybe some body image concerns and maybe some behavior still. And about 20% remain chronically ill, and we do have a percentage of people who unfortunately do not survive their eating disorder. And again, we talked about eating disorders having the highest mortality rate out of any of the eating disorders. Within the boxes, there were criteria for inpatient admissions that both should look at both kind of physical criteria, that is more kind of what we go with for the anorexia one. Usually that's how we can get criteria for insurance companies to pay. And then for bulimia nervosa, we go for the physical complications, but also a lot of times the psychological complications too, such as like major depressive disorder or non-suicidal self-harm, interfering with the ability for us to fully treat the eating disorder. And I think that wraps up most of the article and answers the questions. Any questions that you guys have that I could answer?
Thank you. I haven't seen any specific questions. That was a really nice summary of both of those and some information on binge eating disorder. So thank you for that. And thanks for giving us your personal experiences with like the screening questions and things like that. So that's helpful.
No problem.
All right. Yeah, if nobody has any questions, then we will wrap up I am actually going to do a separate video in a few minutes just with some group announcements. I don't want to tie up this video. So we'll end this one and then I will come back on in maybe 5 minutes or so just to give you guys some updates on group happenings and things like that. And thank you again, Dr. Garber. It's a lot of work to do these, especially 2 in a week. So we really appreciate it.
No problem. Thank you.
All right.
Bye-bye.
Thanks, guys, and we'll see you later. All right. Bye.